Welcome to this Beyond Zero e-learning module, which is one of the Wits RHI Advanced TB and HIV catch-up sessions. This particular one is part one of two different lectures on the failing art in children. We are going to be going through a few cases looking at virological failure in children and how we think and approach children whose viral loads are not suppressed on treatment. And we're starting off with a case of a mommy who arrived, Tembi, who's 34 years old, and she's HIV infected. So she lives in Johannesburg, and her two children, Lerato and Sipho, both live in Mpumalanga with Gogo, and they're both HIV positive. She was initiated on the FTC 12 months ago, and her CD4 count at that stage was 150, and she's never suppressed since starting on treatment. She now presents at your ARV clinic for her routine visit, and she's found to be 5 months pregnant. As per the guidelines, a viral load is done immediately as she is pregnant, which shows a viral load of 40,000, and her CD4 cell count is now 400 cells. So to look at how we're going to review Tembi today, I want to do some quick revision out of one of our previous lectures on art management of failure in adults. And every adult and child, we'll speak about that more today, who are failing needs to be systematically approached to see what might be contributed to a failure and to be able to differentiate that from resistance. And we follow a simple ABCD to remind us on all the things we need to look for. A is obviously standing for adherence. B for bugs, looking for other opportunistic infections such as STIs, TB, deworming, etc. Making sure they're on the correct dose, especially if they're, for example, renal patients. And D, looking at any drug interactions or other medication that might be interfering with the viral load. And of course, because Tembi is pregnant, we'll be checking the viral load again in 1 month's time. We're not going to be spending a lot of time on PMTCT in this lecture. Please see the PMTCT module for that. But there's a few key points with Tembi that we just would like to highlight. The first is to already start looking ahead at baby feeding options. So at the moment, Tembi is not suppressed. We're going to check another viral load in a month to see if she will suppress if she takes her treatment properly. But if she's still not suppressed by the time she delivers, there might be more advisable for her to formula feed her child. And it's one of the very, very few indications of formula feeding. If we are going to consider formula feeding in Tembi, we have to make sure that as a clinic or as a hospital, we can reliably supply that mom with formula for 6 months. And the decision-making and all the discussions need to happen while she's still pregnant, not on the day of the delivery of the baby. We can also start thinking ahead a little bit of prophylaxis. If this mommy does not suppress by the time the baby is born, if the viral load is still over 1,000, we're going to be concerned that there is resistance to the efavirenz and possibly cross-resistance to nevirapine in the mom. And therefore, we don't want to give the baby nevirapine on its own. And the baby will be receiving their nevirapine and AZT for at least 6 weeks while we're still trying to sort out the mom's viral load. A big concern, obviously, about this baby is not only about transmission, but the transmission of a resistance virus. And that needs to be kept in mind at all times. If this baby does become HIV infected, we're already concerned that she might have a resistant virus at that stage. And very important, as soon as the baby is born, we would want to birth PCR to identify these issues nice and early. So let's continue with Tembi, and she had another viral load a month later. The viral load was still high. At this stage, we were fairly confident we had addressed the ABCD issues, and so therefore Tembi was changed to second line, AZT, 3TC, and Illuvia. And Siatemba, a little baby that was then born, fortunately is HIV negative at her birth PCR test. But Tembi is now concerned about Lerato and Sipho, who's now living with her in Johannesburg. She was told when she went to fetch them at the clinic in Mpumalanga that both the children were failing treatment, and she was scolded by the staff, who says that she's irresponsible because she hasn't been giving the art. But in reality, it's Tembi's mom, the Gogo, who's been looking after the children, and she's been struggling to remember, especially with 2 children, difficult, complicated dosing, and is also developing cataracts, struggling with her vision. So let's look at these two children at home, and we're going to start off with Lerato, who is the youngest of her two children. And Lerato is 2 years old. He weighs 9.5 kilograms, and if you were to plot that on a chart, you would see that he was underweight, between a -2 and -3 Z score. And we saw that Lerato was started on ARV 9 months ago, so when she was just over a year old. And that is her dosing: Kaletra 1.5 3TC formal BD and Abaco formal BD. But Lerato is also on the continuation phase of TB treatment. She received nevirapine when she was little as 6 weeks as post-exposure prophylaxis, and otherwise she's clinically well. But when we do her bloods, we see that the CD4 count is 1,000, 30%, which is good, but the viral load is 6,523, done 3 months previously. So there's a few things we want to think about now in terms of why her viral load is up, how we're going to manage it. And the big question in our mind is, might this already be resistance? And if it is, what can we expect to see with the resistance patterns? So let's look at these in more detail. So firstly, we need to now address the fact that Lerato's viral load is not suppressed. And we're going to use the same approach as we did to TB. Again, we're going to look at A for adherence, and very important in children, it's all about the carer. So we also need to look at who looks after the child, and a good question to ask is who puts the child to bed and who wakes the child up in the morning every day. That includes your holidays, includes your weekends. Who are all the people who is responsible for giving this child treatment? And then with adherence with children, the acceptability of medicine is a big issue. Firstly, the taste. Can they manage the very bitter Kaletra? And if there is tablet treatment, how is the mom managing that? And then as the child gets older, disclosure will become more and more of an issue and important to check. B stands for bug, opportunistic infections, and in children, very important to remember to deworm. All the littlies are supposed to be dewormed every 6 months, and we often forget that when we see viral load failure. It might not give you a very high viral load, but it can certainly give blips or little peaks in viral load. We obviously want to look for TB, and we want to check the skin. Just a severe nappy rash can also contribute. In children, the correct dose is almost one of the most important things, and one of the things you're going to check first. The children must have had a weight done in the last 3 months and must be on the correct dose for that weight. And many children sometimes outgrow their dose, and that's not picked up. And that is a fault then of the healthcare worker if that child fails treatment. And then drug interactions, very useful to ask about medicines over the counter. Medicines may be provided by traditional healers, by kind aunties who's brought something that they think might help but might interfere with the ARV absorption. So if we did the ABCD now on little Lerato, our little 2-year-old, we already know, we've heard that the granny has not been managing, been struggling to see the bottles, maybe the correct dosages was not always given. When we think of opportunistic infection, so Lerato's already on TB treatment, but she's on continuation phase now. If we were to expect the TB treatment to have contributed to the failure because your immune system struggles to multitask, we would have seen that earlier on in treatment when she first started on TB treatment. We're checking the correct dose, very important, and she's on the correct dose for her weight. But our big worry here is when we look back, is we notice that she's been on a Kaletra-based regimen. She's also been on TB treatment, and the Kaletra has not been super boosted with ritonavir or doubled since she's been on TB treatment. And this is probably our biggest concern. And let's look a little bit more at that. So we mentioned that her big issues is the adherence issues with the granny. There is a separate module, an e-learning module on adherence. Please check it out. It gives a great approach on how we manage these children or adults failing on treatment and trying to figure out what are the obstacles to being able to take their treatment. In children, medication factors is a major factor. Now, adults, not so much. We've got the 1 tablet a day. But in children, the formulations are often complicated. They might taste horrible, storage might be more of a challenge, and also the dosing changes as the child grows older. And in patient factors here, it's all about the carer and being able to understand if the carer is managing and how many carers are involved. As the child grows older, the issues around disclosure in adolescence becomes very important. But for Lerato, I want to focus on this particular trial that came out in 2011. And when we are giving children on lopinavir-ritonavir TB treatment, we have the challenge that the rifampicin massively reduces the level of the lopinavir in the blood because of its effect on the liver. And because of this, we've always said that it's important that the lopinavir-ritonavir must be boosted, either by giving super boosting with extra ritonavir or by doubling the dose of the Kaletra. And because of the challenges around single dose ritonavir, especially around its expiry, it's got a very short shelf life, there's been a tendency to always just double the dose of the lopinavir-ritonavir. But unfortunately, this trial, looking in small children, found that actually this is not good enough. And they particularly looked at 17 young children and were looking at the pre-dose lopinavir concentration in those children who had double-dose lopinavir versus those that was on normal dosing. And they discovered that the double-dosing lopinavir-ritonavir is not good enough in terms of covering for this rifampicin effect. So just let's look at another presentation done at Croy in 2010 by Moodley et al., where they were looking at children already on TB treatment and double dosing the lopinavir-ritonavir or super boosting the lopinavir-ritonavir. Although the findings was not clinically significant at 6 months, there was already concerns about a difference in suppression between the lopinavir super boosted group and the double dose group. But if we look at 12 months, we can see that overall the lopinavir super boosted group did better than the children in which we double dosed the lopinavir-ritonavir. In summary, at the moment, the recommendation in small children is that we only double dose the lopinavir-ritonavir of children on TB treatment if we have no other option. As far as possible, we should try and order in ritonavir early and super boost with ritonavir using the 2013 dosing chart to ensure that the lopinavir dosage is adequately boosted while the child is on rifampicin. As we're talking about TB HIV co-infection, this was just a particular sidearm as well of a study of children in a large clinic in Soweto. And one of the things they noted was the very high rate of HIV TB co-infection rate in that particular cohort of children. And what was concerning is the high mortality rate, especially in the first 90 days of starting ARVs. The higher the viral load is, the more likely the children were to die. And if there was TB co-treatment, there was also a more likely chance of virological rebound or failure. So this highlights this concern of children who's had TB treatment in the past. If they've been on ARVs, we certainly have that as a red flag for possible resistance and failure. So how should we manage Lerato today? Well, let's look a little bit back at our guidelines. So the viral load is over 1,000. The last viral load was done 3 months ago. So we could actually recheck our viral load today, but it would only make sense if we're fairly sure that the adherence over the last 2-3 months was pretty good, and therefore we can now judge child's on the correct dose. If she's taking a treatment, is this treatment still working? Now, usually if the viral load is over 1,000 and the child's on a PI-based regimen, you will notice there that there's not that much of a rush. And we would actually usually discuss with an expert if the viral load is over 30,000. But do notice on the bottom there, if the child received an unboosted PI in the past or received TB treatment while on a lopinavir-based regimen and the viral load is over 1,000, you would actually discuss these children already for genotyping, because these children have a risk factor for having developed PI resistance. So just a note on viral load assessment. If you are on ARVs that are effective, so there's no resistance, we expect the viral load to come down dramatically, as much as 1 log every 4 weeks. And therefore, the way we assess a viral load that's increased is by increasing the adherence counseling, identifying the obstacles to adherence, addressing those obstacles, and then after a period of good adherence, we redo the viral load. So generally, if the viral load is over 1,000, we're going to do another test within 2 or 3 months after that, and we want to try and make sure that the adherence is very good during that period of time. If the adherence is over 90% during those 2 or 3 months, and the viral load has not yet come down by that log a month after that period of time, then we're going to assume that there is viral resistance present. So let's just look a little bit at some of our information that we have around second-line biological failure and the need for second-line of children in South Africa. And you can see there the 3-year probability of virological failure among a large cohort of children on a whole range of different regimens was as high as 19%. So 1 in 5 children may very well be failing by the time they've been on treatment for 3 years. There are particular regimens that's worse than others. Interestingly enough, your nevirapine regimens and your ritonavir only, which we don't use. But also note that exposure to PMTCD, so children who had nevirapine, can also be associated with higher risks of failure later on. Of those children who were then follow up after their failure, 38% were switched to second line. And it's important to note that there was a significant number of children who did resuppress with good adherence counseling and addressing the factors underlying. And it takes about, between failure and switch, about 6 months before the children were switched to second line, trying to address those issues. So the important thing is that we want to switch children to second line because there's a resistance. And if you have a child who's got poor adherence, we normally don't switch them to the next regimen unless we're absolutely sure that those issues have been sorted out. Otherwise, the poor adherence issues will simply be carried over to the next regimen, and that's especially important of children on PIs. Also remember that there is a risk of higher resistance if there was PMTCT programs and the child's now on an efavirenz-based regimen for whatever reason, or if there's a history that the child has had TB treatment and there wasn't super boosting with ritonavir. Just a small note on the adherence issue. In children, we are very strict about this because adherence in children should be able to be addressed. In adults and adolescents, if you have long-term issues with adherence, there does come a point where we would say there's definitely resistance now, and our second-line regimens are certainly more robust in managing poor adherence than first line. But the bottom line is first address your adherence, and if you're considering changing and the child is still not getting their treatment regularly, discuss with an expert. So with everything we know regarding resistance and resistant patterns, let's think a little bit in terms of what do we think might be happening with Lerato in terms of resistance. What are all the issues we need to consider? And Lerato is on a protease inhibitor, and as we know, it's very difficult to develop resistance to a PI. So Lerato is only 2 years old. And if she hasn't been on TB treatment, we would actually be assuming that it's all adherence, and we would be quite happy that she'll safely resuppress once we've sorted out all the issues with the treatment. But in Lerato, due to the suboptimal dosing, and we have evidence that she's not been boosted, there is a higher risk that she may already have developed a resistance to her lopinavir. Other resistance patterns, if she has lost the lopinavir, ritonavir, she may very well already have lost the 3TC as well. Very easy to develop the M184V mutation against the 3TC, and she may already have lost tobacco as well. Looking at her past history, she had 6 weeks nevirapine, so nevirapine efavirenz may not be an option once she's over 3 years old. And she's still on treatment for TB at the moment, so we also need to make sure that whatever we give her doesn't interact with her TB treatment. At the moment, adherence apparently is good, but we have a history of poor adherence with the granny, and that could have contributed to issues. And therefore, if you overlook at a scenario like this in a child who's on a PI and where you are suspecting resistance to the PI, genotyping becomes very important in these cases. So let's look a little bit at HIV drug resistance to help us go through the scenarios where genotyping might be indicated in children who are failing on treatment. This is just a reminder slide from our HIV resistance lecture to remember that all ARVs are not equal, and it's easier to become resistant to some ARVs than it is to others. So, for example, the HIV virus only has to mutate once to be able to lose drugs like nevirapine and efavirenz, but it has to change several times to become resistant to stavudine and zidovudine 3 or 4 times. And when you look at your PIs, your lopinavirs and darinavirs, it actually has to mutate 8 or 9 times before you will get resistance to those drugs. This is a study from the journal, published in the Journal of the International AIDS Society, that was looking at PI resistance in children. And these were all children who were failing on second line, and 17% of them had major PI resistance mutations. But interestingly, they were all related to children who had received ritonavir as a single PI, something we shouldn't see often in South Africa. They're all obviously at the M184V. We'll talk about those mutations in part 2. And about 50% of them had actually quite a relatively low viral load, between 1,000 and 5,000. A third of those had TAMs, and we'll also speak more about them in the next, in part 2. The other important resistance pattern we need to look at is that of nevirapine resistance. And the concern is that because it only takes a single mutation to lose your nevirapine, even with in the old days when we used to give single-dose nevirapine for PMTCT, there was quite a high rate of resistance noted to nevirapine in both moms and babies. And the trials, there's a very huge confidence interval in terms of how often we would expect that to happen. But certainly in the MASHI Plus study, they were comparing children who had not had nevirapine and those who had nevirapine. And there was a significant higher risk of failure in the children who had been exposed to PMTCT when they were littler and later used a nevirapine-based regimen. This is a study that looked a little bit at the drug resistance among newly diagnosed HIV-infected children. And what was interesting in those that were PMTCT exposed, and a lot of children had been PMTCT exposed, as much as 56.8% already had NNRTI resistance or mutations against NNRTIs. And that was strongly related to a younger age. A little bit concerning is that even those children who had no reported or recorded PMTCT exposure, there was already a 24% rate of NNRTI resistance detected, and might be showing what is happening in terms of primary resistance that is being transmitted from the mom. So they actually did a study designed to also look at children who had been single-dose nevirapine exposed and those that had not been single-dose nevirapine exposed, and looking at how they did on lopinavir-based regimens and nevirapine-based regimens. And this was called the P1060 impact study over a 36-month period of time. And then these children were all looked at outcomes. How were they doing at the 48-week visit? Those children who were on a nevirapine-based regimen versus a lopinavir-ritonavir-based regimen. And in summary, there was a much higher rate of failure in the nevirapine group versus the PI group. In those of the children who are failing on the nevirapine group, more than half of them had resistance on a resistance test where there was resistance tests available. There was also more toxicity and also high mortality in the nevirapine group. A third study I would like to mention is the PENPACT study, and very worthwhile knowing about. In this study, they compared at which point it's useful to switch. So do we use a viral load of 1,000 or a viral load of 30,000? And they compared both children on PI-based regimens and NRTI-based regimens. And one important thing is that all these children actually did very well, both whether they were on PI or efavirenz-based regimens. These children actually did very well. And in terms of viral outcomes, there was no difference between switching at 1,000 or 30,000. Actually, both children did quite well at 4 years. But they did note that more children had accumulated NRTI-resistant mutations over the 5 years in an RTI group, switching at 30,000. And this is a bit where the recommendation has come from, that if the viral load is over 1,000, we will already start working children up towards second line if they're on efavirenz or nevirapine-based regimens. But if children is on a PA-based regimen, the PI is quite protective of the NRTIs, and we can wait as long as for the viral load to be over 30,000 before we consider changing to a second line regimen. It just means we have a bit more time. And this is the last little study about looking at lopinavir-associated mutations as well in children. And what I would like to highlight out of this particular trial is that many children achieve biological suppression while remaining on lopinavir-ritonavir even after prior failure. So if you have a children on lopinavir-ritonavir, I really should be focusing to get them, to try and see if we can get them resuppressed through good adherence counseling. Great, so we're still with Lerato and where we're going to go next. And look, what is our options for Lerato? And in a scenario like her, genotyping resisting is definitely indicated, and we'll run through all the indications in a minute. We know that the previous daily nevirapine may compromise efavirenz. We would like to continue using the lopinavir-ritonavir as possible. We're not sure if there might be resistance because of this because the ritonavir was not super boosted. We don't really have that many options in a 2-year-old. So darunavir, for example, is not yet registered for the under 3 years old. We don't have good dosing. So if we can still use the lopinavir-ritonavir, that would be good. The backbone will probably be AZT and 3TC to keep the M184V mutation going. AZT because she's not been exposed to AZT in the past. There is a question about 3TC monotherapy, something that we will discuss a bit more in part 2, but we would not consider it in a child of this age. And there's a good chance that if she has developed lopinavir-ritonavir, that she will need a third-line ARV regimen that needs to be specially designed depending on the genotype test. And of course, whatever we're going to give her, we need to make sure it doesn't interact with the TB treatment. A few important caveats around resistance testing. It's good in being able to exclude a drug from a regimen, but it doesn't always tell us which drugs to include. It doesn't detect resistance in minor variants, and your clinical history is still going to be very important. But very important, to do a resistance test, the patient actually must be on the ARVs or must have stopped within the last 4 weeks. The reason for this is that if they are not on ARVs, the wild virus will once again have a much better chance of survival, and a lot of these resistant patterns can just be shelved and we might not be able to see them. And the viral load must be over 1,000 to be able to get a good sample to do resistance testing. So the next 3 slides is going to give some nice basic criteria you can use for HIV drug resistance testing in children. If you're in a district hospital setting, for example, or in a CHC and you are seeing children who are failing treatment. Our first group of children are children who are failing on first-line lopinavir-ritonavir if the child had been failing for more than 1 year, so the viral load's been up for more than a year. You're fairly sure the patient is adherent to treatment, so 80% or more of the dosages are being taken. And the viral load is more than 30,000 on 2 consecutive readings, more than 3 months apart. So if you meet all of those criteria, those children is an indication for a resistance test. Our second group of children are children who is on first-line lopinavir-ritonavir, who has a TB history, and the following criteria are met. So these are children who are failing on first line, and they're on a lopinavir-ritonavir-based regimen. Child's adherent to treatment, and there's a history of TB treatment while on lopinavir-ritonavir, which was not super boosted. And in this scenario, we will use a viral load cutoff of over 1,000 on 2 consecutive readings, more than 3 months apart. So note, in these scenarios, we are more suspicious of resistance, and that's where we're going to do a genotype. Where in our previous group, we can wait longer. The viral load can be over 30,000 before we're going to start worrying about resistant strains. And our third group, which is often forgotten, is that any newly diagnosed neonate where mom's failing a regimen qualify for a genotype. So this is any neonate or infant who is PCR positive and where the mother has failed ART during breastfeeding or pregnancy. So the viral load is unsuppressed, the mother will already be on a PI-based regimen as we've been suspecting resistance or we have proven resistance. And those babies, before we design regimens for them, we need to know if what resistance patterns they've inherited from the mother. Thank you very much. There is a part 2 where we will be looking a little bit more at some of the actual theory around the resistance mutations, as well as discussing another case scenario.